Hello, everyone, and welcome to Behind the OR, the Peter Surgical Podcast channel, where we invite experts to reveal to us what's happening behind the closed doors of the operating room. Together, we will explore surgeries and procedures and discover more about a surgeon's life in their daily mission. Take off your gloves, take a breath, and let's talk behind the OR.
Hello everyone, it's Dr. Hassan DEBBAGH, a cardiothoracic surgeon in Morocco. Welcome back in our new episode of Behind the OR with Peter Surgical. In this capsule, we're going to talk about building a team, who and how. The concept of a team is not always what one might expect. Indeed, this entity varies in definition depending on the socio-professional culture in which we operate. In the first episode of this podcast series, I spoke about my very first professional experience in Morocco. I would not describe it as a failure, but rather as a lesson. The surgeon I joined and I did not share the same long-term vision. For me, the project was about expanding an existing activity. For him, it was about asserting himself as the head of a team of two surgeons within an association. Our medical contacts were bound to overlap in a tight-knit medical community, which, in his view, became problematic. Instead of seeing reinforcement and support, there arose a fear of competition. Such are the challenges of private practice in an environment where the desire for leadership, the illusion of power sometimes, and the relationship with, let's say, money, can lead to misunderstandings and unfortunate tensions. One might have thought that bouncing back from this would be very difficult, but let's say that cardiovascular surgeons are not exactly in abundance in Morocco. As I mentioned in our previous episode, the ratio is 3.5 cardiovascular surgeons per million inhabitants. A few weeks later, a proposal came from a cath lab friend who was similarly disillusioned with the same individual, a symbol of a system whose values did not align with ours. We were fortunate to be approached by a structure where a medical surgical cardiology project could be envisioned. Let's talk about the importance of surrounding yourself well. Professional benevolence must never be considered a luxury. However, as one of my mentors aptly said, being nice is not a profession and trust does not exclude control. Given the life-critical nature of our specialty, everything must be secured in advance for maximum safety. Just as a pilot in a cockpit reviews a checklist to ensure the flight plan and the technical compliance of the aircraft, you must also verify several key elements before committing to any project. Before saying yes, you have to ensure that certain prerequisites on which no compromises can be made are met. The structure hosting your activity or a future activity must have an operating theater that complies with ISO standards for prosthetic surgery, including regulated biocleaning, airflow control, and temperature regulation. The operating room must have basic equipment, monitors with external displays, tiltable operating tables, surgical lights, an electrosurgical unit, wall-mounted suction systems, and oxygen and air outlets. The cardiopulmonary bypass machine must also meet standards, require a technical inspection by the vendor or a service provider before use, and have it inspected by an experienced perfusionist. Assemble the instrument trays yourself and ensure the sterilization and maintenance circuit is well organized. If the equipment provided by the structure is not adaptable to your surgical technique, demand suitable equipment. Ideally, you should not have to change your way of operating. Never overlook checking the availability of external pacemakers and their cables, defibrillators with adult and pediatric internal paddles. Do not hesitate to visit the ICU and the inpatient wards to check the quality of monitoring systems, bed ergonomics for CPR mode, alarms and patient facilities. Locate the emergency cart and check its contents, especially for a backboard and the necessary tools to ventilate a patient in case of cardiopulmonary arrest. If you are in private practice, you will also need to collaborate closely with the pharmacist of the structure to secure consumables that align with your practices and provide the best quality to cost ratio. My experience has shown me that it is essential to request quotes from all suppliers and negotiate prices. Leverage competition, but remember to build partnerships with everyone. The shortage of circuits, oxygenators, epicardial electrodes, and valve substitutes has also taught us not to rely on a single supplier. Test all the products and request samples for simulations, from sterile draping kits to ligatory threads and textiles. Once the logistics are secured, focus now on people. The physicians you will work with likely trained in different schools and may have different approaches to care. To ensure patient safety, assembling a perfect team is imperative. The anesthesiologists and intensivists handling perioperative care must be experienced in cardiac surgery, as should their anesthetic nurses. The paramedical teams, inpatient, ICU, and OR staff must understand the unique profiles of cardiac surgery patients, particularly if these teams are not dedicated and must work across multiple specialties. Do not hesitate to seek advice from your mentors, whether they are from public hospitals or private practices. They have faced similar challenges and can save you time by helping you avoid certain mistakes. Personally, I sought the expertise of my mentors, former colleagues and friends from Paris, Toulouse, Annecy, and Rabat. How do you build a cardiovascular medical surgical team? This is a challenge that is both logistical and human. It is essential to first define the short, medium, and long-term objectives of the activity. These objectives will determine the resources that need to be mobilized. Regarding team composition, you must actively participate in selecting the profiles. An anesthesia and intensive care team must be skilled in cardiac surgery, proficient in managing CPP, and comfortable with echocardiography, particularly transesophageal echocardiography. In a private practice setting, finding qualified paramedical staff is more challenging, as these profiles are rare and often loyal to existing teams. You will need to train inexperienced staff. This lengthy process requires patience and teaching skills. Personally, I refreshed and updated the lessons I had taught in nursing schools: anatomy, physiology, pathology. A rapid but comprehensive training on the CPP machine, its components, setup, weaning and removal was necessary. We watched several videos of the different stages of surgery to familiarize the team with open thoraxes and the beating heart in situ. It was also crucial to learn the names of specific instruments and dedicated consumables. Several simulations were required to master all perioperative stages, from patient arrival in the OR to positioning on the operating table, to skin preparation, urinary catheterization, setting up the bridge and back tables with instruments and consumables, sterile draping, instrumentation, patient transfer to ICU, and more. This phase lasted at least 2 months, during which we added a 1-month practical internship within an experienced team. I take the opportunity to thank the team at Clinique Agdel in Rabat for their invaluable help. Let's now federate the team. Once the team is assembled, it is crucial to unite all collaborators, medical, paramedical, administrative, and investors, as we are in private practice context. The early stages are predictably frustrating. Insufficient patient recruitment, a long learning curve tied to low surgical activity, longer operative times, and reduced profitability compared to the initial investment. Awareness of these challenges allows for greater peace of mind. Building your network of medical contacts will not happen overnight. To avoid improvisation, the project must be clearly written, with a permanent heart team consultation as its guiding principle. An organizational chart will define everyone's roles and prevent task overlap. This also ensures safety by clearly delineating responsibilities. Once roles are defined, the next step is to write care protocols: pre-operative, peri-operative, ICU, and inpatient protocols. Everything must be addressed, from skin preparation and central line dressings to drain management. Emergency procedures, return to the OR, ICU interventions for cardiac arrest due to tamponade, etc., must also be written and displayed. The pre-prepared emergency cart should be accessible and clearly identified. Everyone involved in patient care must be familiar with emergency protocols. As final thoughts, private practice can lead to many disagreements, whether moral or material. Discuss responsibilities and obligations with your future collaborators beforehand. Address topics like exclusivity, expected quality of care, mutual commitment to team training, quality improvement initiatives, development projects, cooperations, and fees. Several templates for agreements are available online. In conclusion, do not embark on a surgical activity without clear boundaries. It is first and foremost about patient safety, but also about maintaining the trust of collaborators and medical contacts. While therapeutic risks and patient mortality are an unfortunate statistical reality, failing to make every effort to prevent errors and avoidable accidents is an ethical failure. Strive for excellence.